I'd like to welcome Dr. Bryan Cannon, who's going to be teaching us today on the basic principles of reading a pediatric ECG. He's coming to us, as Dr. Horner introduced, from Mayo Clinic. And we're excited to have this refresher. So thanks, Dr. Cannon.
Well, thank you very much, Dr. Anderson. It's truly a privilege to be here. And, you know, the pediatric cardiology and the pediatrics in North Dakota is on par with any place in the country. So it's really an honor to be participating in this. I've been coming to North Dakota for about 10 years. And Dr. Horner was one of the very first fellows that I ever trained. So I'm very proud because when I came, I'm like, wow, these people are really smart here. So it's really an honor and privilege to be here. Can everybody see the screen?
Yes, we can see it.
Perfect. Okay. Well, and we'll kind of go through this, and this is going to be kind of a whirlwind tour. I do have this disclosure, but nothing will be relevant to this talk. So the objectives of this are understanding the basic principles about reading an EKG. And what's the difference between EKG and ECG? Well, it was originally developed in Germany, so it's electrocardiogram with a K, but in the United States, we think we invented everything, so we changed it to a C. So EKG and ECG are synonymous. So when we look at these, we're going to adopt a systematic pattern of reading ECGs, recognize abnormal findings on the ECG, and integrate these ECG findings with clinical presentations. ECGs are very intimidating. It's a bunch of squiggles on a page. But if you read an EKG methodically and compulsively, and you have a basic understanding about the EKG setup and cardiac physiology, it's actually not that challenging to read an ECG. Don't tell anybody because I'll lose my job, but it's not. And actually, as a pediatrician, you don't have to know the subtleties of reading an ECG. What you need to know is normal, abnormal. Okay, and abnormal is abnormal I need to see now, or abnormal we need to evaluate in the future. So that's kind of the goal of this talk, is to show you some basic principles about the ECG. And it's not going to make you an expert in reading an ECG. I mean, Dr. Horner has been doing this for 10 years, and there's still things or subtleties that he and I both look at and go, that's unusual. But the main goal is to say normal versus abnormal. So if it's abnormal, you can say, okay, somebody else needs to take a look at this. And do I need to do this now in the middle of the night, or can it wait? So when we look at the EKG, basically there's different sections. First of all, there's the patient information. Second of all is the intervals and axis, which the computer is actually pretty good at calculating. Then there's the main EKG tracing, which is all the leads that we'll go through in just a minute. And then there's a rhythm strip. Then here's everybody's favorite part of the ECG, is the computer-generated analysis. Well, this can be helpful, but what you have to realize is if you take a look at the computer reading, if the computer says that it's normal, it's right about 70% of the time. If it says it's abnormal, it's only right about 20 to 30% of the time, because it's designed to overcall things. So a lot of times when you see this, I cross through ECGs every day that say infarction, because it's not true. But the ECG reading program is designed to overcall things. So you can use that as a guide, but also you need to have some basic understanding and say, I agree with that finding, or I don't agree with that finding. So when we look at the leads, we're really going to look at things in two planes. So first of all is kind of an up and down plane, and that's the leads 1, 2, 3, AVR, AVL, and AVS. So that looks at things kind of an up and down plane. So if you think about Da Vinci's Man, because the heart's on the left side, lead 1 is usually straight out to the left, AVL is at the left arm, AVR is at the right arm, 2, AVF is straight down to the floor, and 3. And this will become important when we talk about P-wave morphology. So on the ECG, any force in the heart that's moving towards that lead is going to be a positive or upright deflection on the ECG. Any force that's moving away from that lead is going to be a negative or downward deflection. So that's how we can figure out where things are coming from in the directions of forces. Now, in addition to an up and down plane, we also have a transverse plane, and that's leads V1 through V6. So if you look at this, V1 is to the right of the sternum, and these kind of spread around in specific positions between the 4th and 5th intercostal space. So as most of us don't do ECGs, it's important to have an idea, but as we read the ECG, knowing where these positions are will become important. Well, then what's special about a pediatric EKG? Because if you look at pediatric ECGs, it's definitely different than reading an adult ECG. With adult ECGs, the criteria are pretty much universal from about 20 years up to 80 years. But in pediatrics, because there's so many changes and so many transitions that happen with the heart, there are age-specific findings. And there are findings in pediatrics that we don't typically see in adults. So if you look at this, we add some bonus leads. So instead of doing a 12-lead ECG, we add up to a 15-lead ECG. So basically, we're adding V3R, V4R, and V7. So V3R and V4R are in the same position as V3 and V4, but they're on the right side of the chest. So we can see what's going on in the right ventricle because that's a very important finding in pediatric cardiology. And V7 is behind V6. And to be honest with you, the only thing we use V7 for is so there's not a big gap or hole in the ECG, but there's limited utility to V7. So for all practical purposes, you can ignore that. And we'll talk about V3R and V4R and what we use that for as we go through the findings. So if you took a look at an ECG, we're going to take a look at the basic measurements, okay? So by definition, the first upward deflection is called the P wave. The next is the QRS, then there's a T wave and potentially a U wave, okay? So waves change names when they cross the baseline, okay? So if there's a downward deflection here, this is called a Q wave. If it just goes up, it doesn't cross the baseline, that's still part of the Q wave. In order to change names, it has to cross through the baseline. So if we look at the basic findings on an ECG, each of the small boxes is 1 millimeter by 1 millimeter. And each large box is 5 millimeters by 5 millimeters. In general, there's a standard paper speed. You don't need to remember this number or know this number. Just realize that we can change the paper speed. We can run it faster. We can run it slower, but this is a standard paper speed. So at a standard paper speed, each one of these small boxes is 0.04 seconds. Now, and most things you don't have to memorize about the ECG, but this is one thing that you do. Each small box is 0.04 seconds, and therefore each large box is 0.2 seconds, okay? Also, in addition, we have heights on the ECG, which measures the voltages. But we really care about the millimeters or the number of boxes that it is. So we say it's 5 boxes high or 4 boxes high. We don't really worry about the millivolts. The only time this becomes an issue is if you have an ECG where the voltages are overlapping. And you're like, well, gosh, I can't tell where one ends and the other one begins. So sometimes we need to make the deflections smaller. So in order to do that, we do something called standardization. So basically what we can do is we can cut the voltages in half just so it's easier to see on the ECG, and we can measure it. So if you do something, if you run an ECG at half standard, anything that you measure, you'll have to multiply by 2. And realize that only the voltages and not the intervals are affected by the standardization. So for example, if this is run at half standard, anything you measure time-wise is going to be exactly the same. However, if you measure the height of this R wave here, instead of it being 3 millimeters, it will be 6 millimeters. As we've gone to more electronic ECGs, this has become less of an issue, but if you get printed out copies, your technician will sometimes change the standardization. So how do you tell if the standardization has been changed? Well, there's this little calibration box at the start or end of the ECG. So a standard scale will go up 10 boxes and come down 10 boxes. So that means whatever you measure as far as boxes is the same. If it's half standard, it will only go up 5 boxes. So if it only goes up 5 boxes, any of the voltages that you measure throughout the ECG will need to be multiplied by 2. And the same EKG can have 2 different standardizations. The first portion represents the limb leads, or 1 through AVF, and the second portion represents the precordial leads, V1 through V7. So if you measure on this ECG, and there's 2 standardizations, any voltage that you measure on this side will be standard. So for example, the R wave here would be 5, 6, 7, and it would be 7. However, if you measured the R wave here, instead of it being 7, because it's run at half standard, as you can see here, and it also says it here, you would multiply these voltages by 2. So instead of 7, it would be 14. So this is a way that you can get fooled that an ECG is normal when actually there's very prominent voltages. So now we're going to move a little bit into reading the EKG, or how you interpret the ECG. And it's also important to be very methodical, just like you read a chest x-ray or go through a physical exam. Always use the same technique. And I'm going to show you the technique that I use, which starts with rate, rhythm, and axis. However, I'm going to skip axis for the purpose of this discussion. It can be helpful, but in general is not incredibly helpful. If you see left axis deviation, the main cause of that would be from an AV canal type defect. That's one of the main causes of left axis deviation, but we're not going to go through those specific findings in pediatrics. So then we're going to move to intervals, wave morphology, and ventricular hypertrophy. And if you go through this basic technique, you will pick up almost all abnormalities of the ECG. So first of all, if we go through the rate, so there's a couple of ways that you can determine what the rate is. So first of all, realize that the ECG runs for 10 seconds. Therefore, it's just like taking the pulse for 10 seconds. So basically, if you count the number of QRS complexes and multiply by 6, you'll get the heart rate on the ECG. The computer is pretty good at determining heart rate, but if you want to check it yourself, this is one way to do it. So for example, on this ECG, there's 25 QRS complexes. So that's 25 complexes in 10 seconds. Therefore, we multiply this by 6, and it's 150 beats per minute. Okay. So that's a quick way to do it. But this also works when the heart rate is irregular. However, if the heart rate is slow and regular, there's a shortcut that we can look at to very quickly determine what the heart rate is. So what we're going to do is count the number of large divisions between two R waves and divide it into 300. So let me show you an example of that. This is the actual formula. I'm not going to go through it, but it will be in the slides if you want to actually figure out what the specific heart rate is. But when we do this, we try to find a QRS complex that falls on one of these big boxes. And then we count the number of large boxes in between these QRS complexes. So this would be 1, 2, 3, 4, 5. And then what we do is just say 300 divided by 5 is 60. So this is a very quick way to determine what the heart rate is. So we can get estimates. So 300 divided by 1, 300 divided by 2, 3, 4, 5, and so on. So you can very quickly look at an EKG and figure out what the heart rate is. So if this is an example of an ECG that we're trying to figure out what the heart rate is, we know that the first box is 300, the second is 150, then 175. So this is about halfway in between. So we would estimate that the heart rate's about 125 beats per minute. So this is a quick way to look at heartbeats. Or if you have a rhythm strip and it's not telling you what the rate is, you can very quickly determine what the heart rate is. So realize that the normal rate is age dependent. So tachycardia is a heart rate above the normal rate for age, and bradycardia is a heart rate below the normal rate for age. So if you look at this, it's actually a size-dependent phenomenon. For example, a hummingbird's heart beats about 1,000 times a minute, and an elephant beats about 35 beats per minute. So really, the larger that you are, the slower your heart rate is. So if you had a baby that came in with a heart rate of 150, that may be completely normal, even as a resting heart rate. However, if you had an older adolescent who did that, that may be too fast for them. And also realize that sinus tachycardia and sinus bradycardia are almost never primary cardiac problems. This is very, very rarely directly related to the heart. So we'll say we have a newborn baby who's getting very bradycardic, and they call me. I'm like, well, you probably should look for reflux, for apnea, for other things, because these are very rarely primary problems. And if they are, they tend to not be episodic. So if you see rapid increases in rate and rapid decreases in rate, that's more likely to have some pathologic mechanism. But in general, just resting sinus tachycardia or sinus bradycardia are not issues. And people ask me, well, how slow is too slow? And I say, well, single digits is too slow. And I say that kind of joking, but kind of not. If somebody's awake, alert, looking at you, different people have different set heart rates. So a very slow heart rate may be perfectly normal for some individuals. And a faster heart rate, 120, 130 resting, may be perfectly normal as well. So we don't have to get that concerned about it or issues unless there are other signs and symptoms. Because I get people who said to me all the time, say, well, my heart rate's 130. And I'm like, well, I don't really care. I mean, as long as you don't have symptoms and you're doing well, that doesn't cause cardiomyopathy. It doesn't cause problems. So I wouldn't be worried about primary sinus tachycardia or primary sinus bradycardia. So if we look at the rhythm, this is an important concept because where the rhythm is generated is from the sinus node. So where's the sinus node located? Well, it's located at the junction of the superior vena cava and the right atrium, okay? So the force starts here and the impulse moves out in this direction, okay? So for it to be sinus rhythm, it actually has to meet 4 different criteria. There should be a P wave before every QRS, QRS after every P wave. All P waves look the same. And importantly, this is something that people forget, is it needs to be coming from the sinus node. So you need to have what's called a normal P wave axis, which means it should be coming positive in lead 1 and positive in AVF. So if you take a look at this, remember that lead 1 is positive straight out to the left. AVF is positive straight down to the floor. So if the impulse is coming in this direction, it's coming towards lead 1. It's also coming towards AVF. So we can say it's a positive P wave in lead 1 and a positive P wave in AVF. So if we look through this, first of all, we're going to go the right direction. So if we look at this, so looking to prove its sinus rhythm, P wave before every QRS, QRS after every P, the P waves look the same, and positive P wave in 1, positive in AVF, because we know that the rhythm can come from a different area other than the sinus node, and based on the way that the P wave looks, we can determine where that's coming from. So if it's negative in lead 1 and positive in AVF, so if it's coming away from lead 1 and towards AVF, then it's coming from the left atrium. So if it's positive in 1, so it's moving towards lead 1, but it's moving away from AVF, and you have a negative P wave that is coming from the low right atrium. So any patient that has a fast heart rate with an abnormal P wave axis should be considered abnormal. So you should, when you look at this, you have to ensure that the patient is coming from the sinus node, because if it's coming from somewhere different and you have a tachycardia, you may have an abnormal mechanism of tachycardia. For example, if you look at this, you're like, wow, this is great. Sinus rhythm, P wave before every QRS, QRS after every P. P waves look the same, positive in 1, oops, negative in AVF. So this patient is slightly tachycardic at a heart rate of 150, but I'll tell you that this patient actually has an abnormal rhythm and actually developed a cardiomyopathy from this because it wasn't that fast. But if you look at this, if the P wave is not coming from the right spot, then you have to think of an abnormal mechanism of tachycardia. And it is not important that you know the specific name of it, but when you realize, hey, this is not sinus, you can send it to somebody, your friendly local cardiologist or electrophysiologist, and say, hey, what do you think about this? Because this is
Good morning.
Did you get an abnormal.
Got my second one yesterday.
I got my second Wednesday.
Did you?
Okay.
This is the only
So
thing I do.
if you look at
I think
this,
Kayla had the same thing with hers.
I'm like, it doesn't
likely
matter. I'm like,
Yeah.
I just noticed it in the
Hey,
chat.
If you're
Yeah.
not muted, can you please mute your lines?
yeah, if you guys don't, perfect, thank you. So if you look at this, the heart rate's slightly fast, but the P wave axis is abnormal. Positive P wave in 1, negative in AVF. So that would tip you off that this is an abnormal mechanism of tachycardia. And I know Dr. Thompson is going to talk a little bit later about SVTs, but this is one way to pick it up. So these are 2 strips. One looks irregular. The other one looks irregular. In fact, they look pretty similar, okay? But what's the difference between them? Well, if you look at this, this is abnormal because you can see that the P wave goes from a normal upright P wave in lead 2 to a negative P wave. So in this particular case, this is actually an atrial tachycardia. Now, this strip that looks exactly the same, you look at the P waves and they look exactly the same going across. So this is what we call a sinus arrhythmia. And a sinus arrhythmia, when you breathe in, the heart rate speeds up. When you breathe out, it slows down. This is much more commonly seen in small patients. So if you predominantly take care of adults, you will not hear this very much. But realize that the heart rate can double when you breathe in and be cut in half when you breathe out. So you can hear a very marked change. The thing is that it's typically associated with respiration. So if you have a tiny baby and you want to show this, if you actually push on the baby's abdomen, they will kind of push against your hand and hold their breath a little bit, and you'll be able to hear their heart rate slow down. So if it's reliably reproduced with respiration, much more likely to be sinus arrhythmia. If it just happens completely at random times, or you see this change in the way that the P wave looks on an ECG, you'd be more concerned about a pathologic mechanism of tachycardia. So sinus arrhythmia is a completely normal finding. The heart rate increases with respiration and decreases with expiration. And they're predictable changes, but they can be very noticeable. Like I said, you can have up to 100% variation. So you may hear this and you're like, wow, the heart rate's really, really irregular. That's great. In addition, the new Apple Watch 6 has an atrial fibrillation feature that this confuses it for. So if you have a patient who says, well, can I use my Apple Watch? You're like, well, yeah, but don't turn that feature on or you may be getting alerted all the time. So now we're going to take a look at intervals, okay? So basically the intervals on an ECG is from the start of the P wave to the start of the QRS is the PR interval. And there's the QRS duration. The ST segment follows this. And then the QT interval is from the start of the Q wave till the end of the T wave. So realize that the sinus node fires here, and then you get depolarization of the atria. It goes through the AV node, and then you get depolarization of the ventricles, and then ultimately you get repolarization of the ventricles. So the PR interval is the time required between atrial depolarization and conduction through the AV node. Realize that this varies with age and heart rate. It increases with age and slower heart rate. So the older you are and the slower your heart rate is, the longer the PR interval is. So there's a prolonged PR interval. It's also called first degree AV block, but as an electrophysiologist in general, we don't like this term because it's not really AV block. It's really just length of time that it takes to go through the AV node is increased. This is almost always from increased vagal tone, but you can see it in myocarditis, conduction disturbances of the AV node, and congenital heart defects. But in general, this is most always a result of increased vagal tone. So if you see a patient with a prolonged PR interval, what you can actually do is say, okay, before you get your next ECG, do some jumping jacks or have your mom yell at you about not doing your homework, and that increases the adrenaline state, will shorten the PR interval, and then you don't need a cardiology consult. So in general, prolonged PR interval is really not anything to be worried or concerned about in the pediatric population. Now, a short PR interval we can see with enhanced AV node conduction with something called Wolff-Parkinson-White, which we'll go over in just a second, and also with glycogen storage disease. So what is Wolff-Parkinson-White, or WPW? WPW is an extra conduction pathway between the atria and the ventricles, bypassing the AV node. So basically, the atria and the ventricle are electrically isolated from each other by the tricuspid and mitral valves. And typically, the only way for impulses to get from the atria to the ventricles is through the AV node. However, in some people, there's an extra muscle bridge that goes across the tricuspid or the mitral valve, and it creates an extra conduction pathway or an accessory pathway. So in sinus, the impulse goes down both the AV node and the accessory pathway. And because there's a delay as the impulse goes down the AV node, and there's not a delay when it goes through this accessory pathway, when the impulse hits the AV node, it goes slowly down to the ventricle, but here it goes across very quickly and activates part of this ventricle early, or pre-excites the ventricle. And that's shown by a short PR interval, okay? A delta wave, which is this initial slurring of the QRS, and a wide QRS, okay? This can be very subtle. It can be very obvious, as in this case. So if you take a look at patients, if there's a short PR interval and there's this slurring of the upstroke of the QRS, this is a patient who has Wolff-Parkinson-White. So why do we care? Well, if you have an early impulse from the atrium and it goes down the AV node but blocks in the pathway, then it turns around and goes back up the accessory pathway and then goes round and round, kind of like a dog chasing its tail. This is the typical mechanism of SVT, or supraventricular tachycardia. So we've taken the sinus node out of the picture, and these patients can have fast heartbeats. However, if we can interrupt anywhere in the circuit, including by giving adenosine, which blocks the AV node, then we can stop the tachycardia, and that's why adenosine works. But ultimately, hopefully you'll send this patient to me, and we can actually put a catheter in there and ablate this and get rid of it. And if we do, it's a permanent cure for the patient and their heart is completely normal. So why do we care about Wolff-Parkinson-White? Well, first of all, they're prone to supraventricular tachycardia. It makes measuring some things on the ECG, including ventricular hypertrophy, difficult to do. And it can accompany congenital heart disease, including Ebstein's, corrected transposition, and hypertrophic cardiomyopathy. So there's about a 20% association between congenital heart disease and Wolff-Parkinson-White. So in general, we get an echocardiogram on all of these patients that we have that. Now, there also can be at risk for sudden death. It's a relatively low risk, about 1 per 1,000 patient years in pediatrics. But what can happen is these patients are at a higher intrinsic risk for atrial fibrillation. So in atrial fibrillation, the AV node typically will not conduct very rapid impulses from the atria to the ventricles. However, some of these accessory pathways can conduct very rapid impulses from the atrium down to very rapid impulses in the ventricle and can cause ventricular fibrillation and sudden cardiac death. So if you have a patient who has syncope, the overwhelming majority of syncope in pediatrics is benign, but if you notice that there's WPW in syncope, that demands an immediate evaluation because that patient may have actually had an aborted sudden cardiac death rather than an episode of just garden variety syncope. And this is an ECG that I show because the boards, everyone else likes to show this because there's very few things that will give you this. So if you see an irregular, wide complex rhythm where all the QRSs look the same, it is most likely to be atrial fibrillation and Wolff-Parkinson-White. And we know the more rapid it conducts to the ventricle, for example, here it's very rapidly conducting to the ventricle, the higher risk for sudden death. But if you see a monomorphic wide complex rhythm, basically it's not ventricular tachycardia, it's almost certainly due to atrial fibrillation and Wolff-Parkinson-White. Now, if the QRSs look different, you could certainly have torsades. So why would you care that this patient is in atrial fibrillation with WPW? Well, this is one of the few instances in which adenosine would not be indicated. In fact, it would be contraindicated because you may actually promote rapid conduction through the accessory pathway and potentially precipitate a dangerous ventricular rhythm. So this is just something that you should imprint in your mind as a finding that we will sometimes see. So at Mayo Clinic, we love the QT intervals, and we have some world experts in this, but I'm going to briefly talk about this. So just realize the computer is terrible at determining the QT interval. In fact, we read the QT on pretty much every ECG that we determine because the computer's really not good. So if you look at all the standards are based on lead 2, but you can use lead V5 or even lead V6 to determine that. I would not use the mid-precordial leads or V1, V2, V3 because there's so much myocardium that's there. You'll see funny looking T waves, you'll see prolongation. So do not measure it in V3 or V4. You should measure it in either lead 2 or V5. So basically the way that we determine the QT interval is from the start of the Q wave to the end of the T wave. But realize that the QT really varies with heart rate. So we actually have to correct the QT in order to determine what the QTC or corrected QT is. And so in order to do that, we take from the start of the Q wave to the end of the T wave and then divide that by the square root of the previous RR interval. So for example, in this ECG, if we look from the start of the Q wave to the end of the T wave, that's 7 boxes. And if you take a look at 7 boxes, each box is 0.04 seconds. So we have 0.28 seconds. And then we look at the previous RR interval. In this particular case, it's 16 boxes. And 16 times 0.04 is 0.64. So if you take from the start of the Q to the end of the T, divided by the square root of the previous RR interval, and don't worry, I won't make you do the math, but that gives you the corrected QT, okay? So we get a question of what's a normal QT interval? So this is a rough guideline. We can spend a whole hour talking about what's normal versus abnormal. So less than 0.45 in infants, 0.44 in children and adolescents, and 0.45 in adolescent females. However, realize that even at a QTC of 470 milliseconds, there's going to be 1 long QT syndrome for every 200 normals. So the fact is there's quite a bit of overlap. So this is something that can be challenging, but just because a patient has a QT of 450 doesn't necessarily mean that they have long QT syndrome. And there are also several other causes. Long QT syndrome, but any type of head injury. Be very careful if you have a patient who passes out and has a concussion or a subdural and you get an ECG and the QT is prolonged, because any type of head injury, syncope, myocardial disease, electrolyte abnormalities can cause prolongation of the QTC, of the QT interval. So it's important to repeat that measurement several times before you make that diagnosis. Now, you can also have too short of a QT interval. So if it's less than 300 milliseconds, you may want to think of hypercalcemia or drugs, but there is actually a short QT syndrome where the QT is very short and they're predisposed at risk for arrhythmias. But fortunately, this syndrome is very rare. So in general, a way to look at things is if you take 2 QRS complexes and you draw a line halfway in between, if the T wave is ending on this side of that, it could be prolonged, and you definitely need to look closely at it and measure it, because these patients are at high risk for ventricular arrhythmias and sudden death. And also realize that drug-induced long QT is just as dangerous as congenital long QT syndrome. So in general, the cutoff that we use is if your QT is if your corrected QT is more than 500 milliseconds, regardless of the reason, you need to take notice of that. And there's this website called credible-meds.org, which lists a site. It's a free site to visit, and it lists all those things. And in addition, as there's a talk on a little bit later about what's concerning, but syncope during exercise is always concerning. So this is just a list of some of the medications, some of the things you wouldn't think about, like methadone, Zofran, Bactrim, and Zopanex, which can prolong the QT intervals. Although ADD medications is on this list, I'm going to go on a little bit of a tangent just to say that, do you need to do an EKG before you start ADD medications? The answer to that question is no, unless there's a specific indication. The problem is if you look at false positives on the ECG, they're between 10 and 15%. So there's plenty of patients that you're going to find, and Dr. Horner will be super happy because he's going to be doing a lot of evaluation and workup on them, but they don't necessarily need it. So before ADD medications, before any psychotropic medications, with a few exceptions, you don't need to do that. And I would encourage you to read the AAP statement based on this rather than the one published by the American Heart Association. In addition, what about sports screening? Well, currently in the US, doing routine ECGs before sports screening is not recommended. There's many different things that go into that, but once again, because of the number of false positives and the need to restrict patients, it's not recommended, because the incidence of having a positive ECG finding, like I said, is about 10 to 15%, but the incidence of actually have something that's dangerous or life-threatening is only about 1 in 2,000. So there will be a ton of false positives if you do routine ECG screening for either sports or for ADD medications. And the current recommendation is that you not do ECG screening prior to either one of these, okay? So if you take a look at there's a deflection after the T wave, this is a U wave, okay? So in general, if the U wave is part of the T wave, or it kind of is molded into the T wave, then you should include that in this correction. However, if there's a distinction between the T wave and the U wave and it comes completely back to baseline, you should not include this U wave, because the U waves will frequently fool you that the Q2 is too long, and the computer will always include this. So if this T wave comes completely back down to the baseline, and then there's a U wave afterwards, you should not include that U wave in the calculation. If the U wave is more than half the height and it's a contiguous thing, then you should include that in the calculation. Okay, if you see this, this is something that would be very concerning. And what you notice is here the T wave is upright, and then it's down going, and then upright, and then down going. So this is something that we call T wave alternators. This is a very, very concerning finding. And if you see this for any reason, this would warrant an immediate cardiology referral, because this is definitely a patient that's at high risk for arrhythmias. So we'll briefly take a look at wave morphologies, okay? So first of all, we'll look at a Q wave. And we all remember from medical school that Q waves are bad. Well, that's not necessarily true, because the Q wave is produced by the depolarization of the ventricular septum, and it is completely normal in an ECG unless it is too large or too wide. When we say too large, there's guidelines for that, but in general, it can be up to 8 millimeters. But if it's too wide, then that is always concerning. So when we say too wide, that's half a box, okay? So if it's more than half a box, that is an abnormality, okay? So when we look at deep Q waves, you can see it in ventricular hypertrophy, cardiomyopathies, or as a normal variant. So we don't really use deep Q waves for that much of a concern, but wide Q waves, more than a half a box, you can see in myocardial infarction, myocardial fibrosis, and hypertrophic cardiomyopathy. So how many of those things are good? None of them. So wide Q waves are abnormal. So anything more than half a box should tip you off. And in this particular case, what you can see is there's these deep wide Q waves in leads 1 and AVL, okay? If you see that, that is a concerning finding. And so why do we see ischemia in kids? Well, we can certainly see it in a patient that has an anomalous left coronary artery. So this is where the left coronary artery arises from the pulmonary artery, which gives actual ischemia. So you can see these deep wide Q waves. Okay. This typically presents at 1 to 2 months of life after the pulmonary vascular resistance drops and the coronary perfusion pressures drop. They can present with signs of heart failure and a murmur, but as babies don't really do anything that's exercise other than eating, a lot of times you'll see irritability with feeding, microregurgitation murmur, signs of heart failure. But if you see these deep wide Q waves, you definitely need to take notice of that and do a further evaluation. So let's take a look at ST segments really quickly. So the ST segment is what we're looking for is the J point, and the J point is where the QRS ends and the ST segment begins. And what we're going to do is we're going to compare this to the isoelectric point on the ECG. And the isoelectric point is the point where there's no electrical activity. So that's actually the TP segment. So in this, there's no electrical activity. So this is the baseline of the heart. So if we draw this over, we're going to look at where the QRS ends and look at this J point. And if this is elevated more than 1 millimeter in the limb leads, 1, 2, 3, AVR, AVL, and AVF, or 2 millimeters in the precordial leads, V1 through V6, then we're going to be concerned. And there's a whole wide variety of things that you can see that will elevate the ST segment. Pericarditis, myocarditis, ischemia, electrolyte abnormalities, or increased intracranial pressure. So what we want to look for is, if you look in pediatrics, you will very frequently see these ST segment elevations. However, this is a completely normal finding. This is something called early repolarization. So in early repolarization, the heart just resets itself early. So basically what you can see is there's a nice smooth upstroke of this and a normal looking T wave. So it looks like the normal ST segment has just been moved off the baseline. Same thing here. If you move this back down, it would look completely normal. So this finding is not concerning. In contrast, if you notice that there's flattening of the ST segment, or it dips down before it comes back up, or even slopes down before it comes back up, these are all abnormal. So if it's in the same direction and there's this nice smooth upstroke, likely to be abnormal versus this so-called tombstone pattern, or this where it dips down and comes back up. So in this particular case, this is a patient who was running on a treadmill, and he noticed that there's ST segment depression, but it's in the opposite direction of the T wave. So if you have ST segment depression with an upright T wave, that would be concerning. And as the patient exercises, here you can actually see it sloping down before it comes back up. So this is definitely abnormal. Here's a couple more examples. Once again, it's very flat and low that we see in patients that can have right ventricular ischemia, or in this patient where it's clearly elevated through there, and this is an anomalous coronary artery. So if you take a look at these, if there's flat segments or if there's not this nice gentle sloping, those are the kind of ST segments that we would get concerned about. And in this particular case, there's also a Q wave more than half a box, which should tip us off that, hey, something bad is going on. This is an urgent situation. Now, these ST segments look very impressive, but if you look at it, it's in the same direction as the T wave and this nice smooth upstroke. So this is actually a normal finding. Now, would I say to completely blow this up? Probably not. It's pretty impressive, but this is a patient that was completely normal. So just realize that when you have this nice smooth upstroke, that would not be something to be concerned about, versus these patients that have abnormal Q waves and abnormal ST segments, in which case it would be more of an urgent situation. If you look at patients who have pericarditis, you can see ECG findings, but you should not use this as the final test, because if you have pericarditis, you only have about a 50% chance of having these ECG findings. So what you'll notice is diffuse ST segment elevation, but the kicker in pericarditis, and one of the most important things, is you'll also see this PR segment depression, okay? We don't exactly understand why this happens, but when you see this PR segment depression and diffuse ST segment elevation, you should definitely think pericarditis, and you should get an echocardiogram. If you're trying to rule out pericarditis and a patient says, yeah, you know, when I lean forward, my pain gets better, and you get an EKG and it's normal, that does not exclude pericarditis. You should still get an echo, but if you saw this finding, it would certainly be concerning for some degree of pericardial effusion. So if you look at things, the number one things that pediatrician gets sued for from a cardiology perspective for missing is myocarditis. So the typical course is that about 2 to 3 weeks before there's a viral illness, and then they come in with symptoms where they're feeling sick. And one of the clues is that these patients are frequently tachycardic, but when you give them fluid, they actually become more tachycardic. And you give them more fluid and they become more tachycardic. So when you think about that, if they don't respond typically to fluid, you have to think, well, is there something wrong with the myocardial pump function? And this is one of the classic findings that you can see on ECG, is with myocarditis, because the heart muscle is sick, then you see lower voltages. So when we say lower voltages, we're talking about the height of the R wave plus the depth of the S wave is less than 5 millimeters in the limb leads, or 1, 2, 3, AVR, AVL, and AVF. This would be a classic ECG, but certainly if you had a normal ECG, that would not exclude myocarditis, because it is not always present. You can also see these small voltages in pericarditis, hypothyroidism, or in tiny, particularly premature infants who don't have that much myocardial mass, okay? But just be careful, because although low voltages are the textbook finding in myocarditis, it's much more common to see ventricular hypertrophy. So if you're concerned about the heart, the best way is to refer it to your cardiologist or get an echocardiogram. So just to briefly talk about this, because it's an important thing to be aware of. So the myocarditis is frequently preceded by a viral illness 2 to 3 weeks before. If you hear a new mitral regurgitation murmur, that kind of low-pitched murmur at the apex, may have a gallop, but gallops are very difficult to hear in anyone, but particularly in infants who have a faster heart rate. You do need to get an echo urgently, as there's decompensation, and realize that rales or pulmonary edema are very unusual in pediatrics, even in severe heart failure. So if you hear rales, it's probably from a pulmonary process, but don't use that as a finding to look for heart failure in pediatric patients, because you will almost never hear them in pediatric patients. Now, this is another classic ECG that we'll see. If you have voltages that are going off the page, You can see it in ventricular hypertrophy and cardiomyopathy, but this would be concerning for something called Pompeius disease or glycogen storage disease type 2. So when you see these voltages that are not contained on the page, you should always think of glycogen storage disease. And this is one of the classic ECGs that they like to ask on the boards. So we always get questions about T waves. What is too much for a T wave? Well, if you have big QRSs, you will have big T waves. That's a normal thing. But abnormally peaked T waves, or if the T waves are more than 2/3 of the height of the QRS. And you can see that in hyperkalemia, left ventricular hypertrophy, or stroke or infarction. When we say pointed or peaked T waves, it doesn't mean little spiky things, okay? It just means these very tall T waves that are more than 2/3 the height of the QRS. And you can certainly see this in hyperkalemia. So the first thing that you'll notice is that there's a loss of distinction between the QRS and the T wave. But if you looked at this, you'd say, gosh, this could be ischemia, there could be things. But if you look at these, once again, abnormal ST segments. But as the hyperkalemia progresses, what you notice is that the QRS gets wider, and ultimately there's loss of distinction between the QRS and the T wave. So if you cannot tell where the QRS ends and the T wave begins, you should think of either severe acidosis or very high potassium, okay? So this sine wave or this loss of distinction should tell you, okay, something is really going on with your electrolytes or your acid-base status. Flat or low T waves are a very nonspecific finding and are not terribly concerning, okay? So we'll talk briefly about atrial enlargement and ventricular hypertrophy. So because the right atrium is on the right side, when it enlarges this way. So there's actually more mass. So tall P waves or big voltages are indicative of right atrial enlargement. And when we say tall, what we mean, once again, is we're going to take the baseline, which is the TP segment, and if this is more than 3 millimeters in any lead, it's most commonly in 2 or V1, but it can be seen in any lead. That would qualify as right atrial enlargement, okay? Whereas the right atrium is typically on the right side, the left atrium is typically on the left side. So when it expands outward to the side of the chest. So that creates a wide P wave. And what do we mean by wide? Well, wide is more than 2 boxes in an infant less than 12 months of age, or more than 2.5 boxes in a child greater than 12 months of age. Once again, most commonly seen in lead 2 or V1, but it can be seen in any lead, and frequently the P wave will be notched or diphasic. So if you take a look at tall P waves, because the right atrium is on the right side and you get more mass, right atrial enlargement. Wide P waves are enlargement of the left atrium. Okay, so in the same way, we can take a look at the position of the leads on the heart and where the ventricles are. So realize that the depolarization of the heart goes down through the septum and then out through the right ventricle, out to the left ventricle. So if you know that V1 is positioned here, if the impulse is going through the septum out this way, then it's coming towards V1. So the R wave in V1 is the right ventricular force. In a similar way, because it starts from the septum and moves out this way, the S wave, or the negative deflection in V6, is the right ventricular force. And the opposite is true for V6, since it starts in the septum and moves in this direction, moving towards V6. So the R wave in V6 is the left ventricular force, and the S wave in V1 is the left ventricular force. So if you can remember that, you know, the R wave in V1 is the right ventricular force, fantastic. If you can't, you can think about where the heart's positioned in the chest and which way the forces are moving, and that will give you the answer. So the ECG in pediatrics is actually pretty good for right ventricular hypertrophy, but the height of the R wave in lead V1 is not the best criteria, okay? It certainly is one, but if you look at the T wave, so realize that the T wave in lead V1 starts out upright, and then after 3 days of age, okay, it inverts, and it stays inverted until they're at least 6 years old. So T wave starts out upright, then inverts, and around six or even older can turn upright, but it can stay inverted, and that's really not that big a deal. But if you see an upright T wave in V1, in a child between 3 days of age and 6 years of age, that's probably the most sensitive thing for right ventricular hypertrophy. Okay, so upright T wave between 3 days of age and 6 years of age. In addition, you should not really see Q waves in lead V1, V3R, or V4. So if you see a Q wave more than one box deep, okay, in V1, V3R, or V4, that's also a good sign for right ventricular hypertrophy. So if you look at V3R and V4, this is one of the things that we use it for in pediatrics, is if there's a Q wave there, that's a pretty sensitive sign for right ventricular hypertrophy. There's a couple of other things that we use. If you have an RSR prime with a bigger R prime than the R, or more than 15 millimeters in a newborn, 10 millimeters in the child, that's a pretty good sign for right ventricular hypertrophy. In addition, if you have a pure R wave in V1 in a child older than 6 months, that's a pretty good sign. And these will all be on the slides that will be on the website. So if you didn't get a chance to write them all down or think about it, you can always go back and review those. So where the ECG is pretty good for RVH, it may not be quite as good for LVH, but this is just to kind of emphasize that point, that if you look at the T wave in lead V1, it's upright at birth, inverts after 1 to 3 days of life, and stays inverted until adolescence typically. So if you see that upright T wave, you should think of different pathology. So this is a patient, for example, that has right ventricular hypertrophy. And if you look and say, well, the R waves are not really that big here in V1. But if you notice that there's an RSR prime with a bigger R prime than an R, there's an upright T wave, and then there's Q wave more than one box deep in lead V3R or V4R, this patient definitely has right ventricular hypertrophy and actually had pulmonary stenosis, even though there's not massive R voltages in lead V1. So there's several different criteria that we use for looking at right ventricular hypertrophy in pediatrics, less of an issue in adults where the right ventricle tends to be less important. So whereas the ECG is pretty good for right ventricular hypertrophy, not so good for left ventricular hypertrophy. If you look at studies, if you have left ventricular hypertrophy on an ECG, you'll only have true left ventricular hypertrophy by echocardiogram about 30% of the time. In fact, this is such a poor criteria that when we were evaluating the criteria for sports evaluation, this is completely thrown out. So certainly you're going to miss patients that have hypertrophic cardiomyopathy, which is the most common cause of sudden cardiac death in athletes. But also you're going to eliminate a lot of false positives, because if you eliminate the criteria for left ventricular hypertrophy based on the V6, your false positives go from 15% all the way down to 5%. So just realize that even though we use this, it's not that great of a criteria. So for left ventricular hypertrophy, if the R in V6 is greater than the upper limits of normal for age, possible left ventricular hypertrophy, not a great criteria. And once you start adding in all of these other criteria, which I've included just for completeness sake, we really drop down to less than 10%. So ECG in pediatrics, not great for the left ventricular hypertrophy. You can't see it. The problem is if you get an ECG and it shows left ventricular hypertrophy, you're kind of stuck because you can't tell between real left ventricular hypertrophy and a false positive based purely on an ECG. So you're stuck getting an echocardiogram. So how about biventricular hypertrophy? Well, sometimes the ventricles, both ventricles can be thickened. So this is a criteria that we use. So if the height of the R wave plus the depth of the S wave is more than 60 millivolts in any lead, that's considered to be biventricular hypertrophy. So this is one of the times we do use the mid-precordial leads to determine something on an ECG. Don't look at the QT segments here because there's so much muscle mass that's here that it's not going to be predictive. However, if you notice that the height of the R and the depth of the S are very prominent, when we say very prominent, more than 60, then that's a good sign for biventricular hypertrophy. Okay, so the other thing in pediatrics we use V3R and V4R is for dextrocardia. So you can imagine if the heart is on the left side of the chest, because these are unipolar leads, the voltages are going to be bigger here. However, if the heart happens to be on the right side of the chest, then V3R and V4R are going to be bigger than V3 and V4. So the ECG definition of dextrocardia is if V3R and V4R are bigger than V3 and V4, then the heart's positioned over there. So in this particular instance, if V3R and V4 are bigger than V3 and V4, you've made the diagnosis of dextrocardia based on the ECG. So I've included some references, but hopefully this has been a basic overview of reading a standard ECG. And like I said, really as a non-cardiologist, all you need to know is normal versus abnormal, because if it's normal, you can say, okay, don't worry about it. If it's abnormal, you can call your friendly cardiologist or electrophysiologist to get help. So I'd like to thank everyone for the opportunity to come here. I love coming to North Dakota when I come there. So greatly appreciate being asked to speak at this, and Dr. Anderson and for the opportunity. So thank you very much.
Thank you so much, Dr. Cannon. You really move so smoothly through EKGs. It's like you could do it in your sleep. It's really a great refresher, I think, for many of us that are practicing primary care. I did have a question come through, and you can answer this question for us. I think we're going to learn some more about it in Dr. Treff's talk.
Sure.
But the question was with regard to EKG recommendations with return to sports after COVID infection. You discussed myocarditis a little bit, and how have these recommendations changed to your knowledge? And we can, I don't know if Dr. Treffs is in the room, in the virtual room. He can also pipe in, or we can talk about this again after his presentation.
Sure. Well, one of the things we know is that we don't really know that much about COVID. In fact, if you look at the studies out of China, about 20% of pediatric patients were hospitalized for arrhythmias. The other 80% were for lung findings. But it wasn't the true myocarditis. We really haven't seen that much of the myocarditis seen in adults. If you look at the study of athletes out of Ohio State University, they said up to 30% have some findings. I think that's probably very much of an overestimate. We really haven't seen the myocardial findings. We've certainly seen plenty of kids who've had this, but as far as myocardial findings and ECG findings, it's hard to say. And in addition, the ECG is not that sensitive. You can see very marked ST segment changes and other things in a patient that just has pericardial irritation and no effusion. And you can also see very large effusions with a completely normal ECG. So I think you have to go based on the myocarditis criteria that are published in the sports recommendation guidelines. But I would use more of an echo than an ECG for return to play kind of things. But if they do have myocardial involvement, the official recommendation would be to probably wait 6 months before participating in competitive sports. But if there's no changes on the echocardiogram and there's just a minor ECG findings, I would not consider that to be true myocarditis.
Thank you, Dr. Cannon. I think this discussion will continue even after this conference as we learn more about COVID's effect on the heart.
Oh, absolutely. I think the more we know, the more we realize we didn't know anything before. So I think you're absolutely correct that there's an evolving thing. In fact, I just had an email sent out from all the members of the Pediatric Electrophysiology Society saying, have you seen arrhythmias with COVID-19? Just because we're all trying to figure out and sort through what's the right thing to do and how worried we should be about the heart or other organ systems with this.
Thank you. I have another question for you, and I don't know, I'm sure you're aware, for the standard EKGs that are done at Sanford, are those the 15 lead, or what are done for kids?
Yeah, in general, 12 leads are the standard ECGs that are done in many places in the community. I mean, Dr. Horner may want to comment on this, but if you really are concerned about the right ventricle or other things, adding those additional leads can be helpful and beneficial. And some people will swap out like V3 for V3R, but I prefer just doing it the standard way. But in general, most ECGs done outside of big centers don't include V3R and V4R, even though the cables are everything else. It's just people don't know how to do it or why that they're specifically doing it.